So history taking of the geriatric population is also very crucial, and it is different from the normal population. How it's going to be different, we will see that. All right. We discussed that geriatric medicine is actually different. It's multifactorial and presents the diseases can also present atypically, and all the problems need to be evaluated, and polypharmacy should be avoided. What are the common problems of the elderly? Osteoporosis, falls, dizziness, urinary incontinence, constipation, dementia, depression, anorexia. So these are common problems of an elderly patient. So we need to know how are we going to evaluate these problems. Okay, a 65-year-old male comes for an executive checkup. How are you going to evaluate her, and what advice you're going to give her for regarding her health management maintenance? So we'll see the history taking. What are the history taking points that you do in a patient who apparently does not have any problem? He or she just is here for medication refill or anything that that he's any problem that he's doing across. So assessment, you will do obviously as you do history taking, as you do in other patients, your current history, past medical history, surgical problems. This is regular. Drug review, we mentioned that the drug review is also very important. We need to see, because why the drug review is important. We need to see that if the patient is getting any, probably the patient may getting multiple medications for the same thing, and this is not required. So that needs to be evaluated critically. And the other thing, and the most important and the unique thing, is the functional assessment. This is the unique new thing add-on. For the functional assessment, how we do it? We do it into two parameters. One is Iadls and the other is Adls. What is Iadls? Iadls is about outdoor activities like shopping, cooking, managing money, transport, using telephone, house cleaning, laundry. So this is these are all activities that you can do it as an outpatient, as an outdoor activity. So you need to ask the geriatric population whether he or she is able to do that or not, or he or she requires support or dependency. ADLs, activity of daily living. ADLs stands for activity of daily living. These activities are bathing, eating, dressing, toileting, transferring from bed to chair. So these are the examples. The list is obviously not exhaustive. In ADLs, the normal routine work and something which is culturally important, then you can also include that in your history taking. But the concept and the point over here is ADLs, if the patient is able to do his or her normal activities inside the home, and Iadls is if the patient is able to do his or her activities outside the home, even going to the mosque and coming back to the mosque. This also will include into Iadls. We need to screen the patient for the vision, whether he or she is able to see things properly, or there's problems. We can do it with the Snellen's chart if available, or you can just grossly observe these things, whether the patient is able to visualize things. You can generally observe that the patient has some hearing problems, so you need to intervene that also. So difficulty in conversation, difficulty in listening, or things like that. So you can observe this, whether the patient has some eye problems, whether or not the patient has some hearing problems or not. Cognitive decline. There is a two things. 3-word recall, and clock drawing. So we will assess these cognitive function of the patient by a brief test, and we will come across we will later on discuss what is 3-word recall and clock drawing. Screen for incontinence. You need to ask the patient whether he or she has to go to the washroom or not, or has some urgencies, frequencies, and things like that. You also need to screen the patient for the depression. And there is a general we don't by the way, we don't do it in an extensive way, as we probably have, as you guys have probably done, have covered in the psychiatric rotation. For depression screening and for cognitive decline, we have just screening tools that can give a diagnosis that this patient may have this cognitive problem or this patient may have depression. So some screening tools which are very brief while you are assessing the patient geriatric population. And also you also need to ask about fall or any gait problems so that you can intervene early. Get up and go test. It's a test where you ask the patient to get up from the chair and walk 10 foot forward. He has to turn back, then come 10 foot backward and sit on the chair. If this whole activity is take less than 10 seconds, that is normal. If requires greater than 30 seconds, that needs assistance, or you can say that the patient is at high risk of fall. So you need to counsel the patient and the attendants that this patient is of high risk of fall. So please try to do some arrangements, special arrangements, in order to prevent this fall. Maybe the famous approaches are that, yeah, you ask the patient to use some some support system while he or she is walking, or when he or she is in the washroom. He needs to have some kind of a rod which he or she can hold it up, because a lot of falls happens in the washroom. And this is because they have some osteoarthritic problems or muscle weakness. So you need to carefully review that and intervene before the falls happen. Now, general health maintenance. You ask the patient to do whether the patient is exercising or walking. How is the nutrition? This is also very crucial in patients with geriatrics, because they tend to eat less because of the dentation problem, because of the loss of taste buds. So smoking in nutrition issue should be dealt. Smoking cessation if relevant. Immunization is also very crucial in those patients, because geriatric populations tends to complicate things up. So we make sure that the patient we immunize for the pneumococcal vaccination and influenza vaccination, and meningococcal if relevant. So we try to give these vaccinations before anything happens. So we need to screen the population and give them the right immunization. And pneumovax once repeated after 75 years. Cancer screening is also very important. You do breast cancer if the patient is female for the mammography, colorectal cancer by annual fecal occult blood testing. So you test for the blood in the stools, which is fecal occult blood, and you can screen it for the colorectal carcinomas in patients elderly, male and female. And some any cardiovascular risk factors assessment also important. um, and there is no role of routine hemoglobin and urine DR and thyroid function tests if there is not indicated clinically. The patient have the major issue that is going on with the patients with the geriatric population is constipation. So they usually have stool passage, difficulty in stool passaging, symptoms present at least 3 of the 12 months, and it's very important. It's a very known cause for constipation. But if the things which are important and is the medications, the causes of constipation. One is the physiological cause, which is actually the gut slowing. The other causes would be medications like antihistamines, anticholinergics, NSAIDs, iron, antidiarrheals, opiates, these calcium channel blockers, anti-Parkinsonisms, these antipsychotics, these are all medications which can cause constipation. So you need to carefully review the medications. Carefully, dietary history is also very important. Some if there is endocrinological, if there is hypercalcemias, or if there is neurological problems, if there is anal diseases or structural problems, so all of these can contribute towards constipation. As you know that we have types of constipation: normal frequency but complain of bloating, slow transit, normal transit, and constipation due to pelvic floor dyssynergias. These are also very common. We discussed yesterday about red flags. So what could be the constipation red flags in the constipation? If the patient develops rectal bleeding, abdominal pain, and new onset constipation in elderly is an alarming sign. Family history of colon cancer can also give you a clue that probably this constipation because of some malignancy. Anemia with the constipation is also indicative of some malignancies because there is some internal blood loss going on, and that's the reason the patient with constipation, if they have anemia along with it, it's a red flag. Positive fecal occult blood is also a positive finding. Unexplained weight loss with the constipation is also a red flag. And refractory to the treatment, you give some treatment and then you observe that the constipation is still going on, so that is something that needs to take care of why it is refractory. You evaluate for anemia, you do hemoglobin. You also examine for the abdominal masses. You can also do digital rectal examination and determine whether the rectal vault contains stool, there is a fecal impaction or not, assess for the anal tone, structure, or any mass, or evaluate the sphincter stone on DRE. So on examination, abdominal mass in the abdomen and DRE from the rectal examination. And if you do evaluation of the labs, you should do anemia, hemoglobin, and maybe FOB, fecal focal blood. What could be the non-pharmacological management? Discontinue the causative medication if this is the cause. Increase fiber, increase fluid, exercise, bowel training, disimpaction. These are all non-pharmacological measures that you do in a patient who is having constipation problems in geriatrics. Pharmacology, you can give some laxatives, bulk stimulants, saline, stool softeners. You can give enemas. You can give some prokinetic agents, some chlorine channel activators, which is named as lubiprostone, which decreases the small bowel and colonic transit time. So this is for the constipation. If you go for the falls, requirements for the safe ambulation. So if you are assessing a patient with fall, you should know that the environment should be safe. What do we mean by that? We have the patient who's living in that environment have a sufficient light. There are no rugs or there's no imbalances. There's no upward and downward. Floor is good. Should not be slippery. Floor should be even and have good grip. The patient should have good vision, freedom from the neurological deficit, or if there is any balance problem. The musculoskeletal problem is good. The musculoskeletal system is good. Cardiovascular status is good. Cognition status is good. So if you are assessing a patient with fall, you should know that the environment he is living is properly safe, number one. Number two, his vision. If you start from head to toe, neurological, then vision, then vestibular, then musculoskeletal, then cardiovascular, and cognition comes later on. So this is how you can assess the patient. Is it safe or is it an increased risk or decreased risk of having fall? Assessments, we should assess for the gait, for any cerebellar dysfunctions, for any postural drop. This is also can lead to fall. So while you are assessing a patient with fall, you should assess the gait, any cerebellar dysfunction, or any postural drop. So these are some of the possible causes. If the patient is unable to stand without use of hands, probably he has myopathies, some knee problems, unsteadiness, some balance disorders, small short steps because of the Parkinsonism. If there is wide based, then there is it's because of the cerebellar disorders. So when you assess the gait, on the basis of this gait, you can make some of the presumptions that what is the cause of this unsteadiness or fall. If there's asymmetry, CVA or flexed neck, knees, slow gait, these are all assessment and the possible causes of these problems. So, how can you decrease the risk of fall? By reviewing the medications. If the patient is taking some tricyclic antidepressants, benzodiazepines, antihistamines, antihypertensives, so you need to review these medications. You need to assess for the postural hypotension, which requires you to take the blood pressure on standing and sitting and then standing. Then you also need to assess for the gait. If the patient is using some devices, using some instruments, or if there is any balance problem, or if there is any what is the kind of gait that he or she is having. Based on that, you can assess the cause of that problem. Some impairment in the legs, some problems in the musculoskeletal problems, resistance and exercises. Vitamin D supplementation is also very important in order to reduce the decrease of risk. Our aim here is not actually to treat fall, but actually to prevent fall from happening, because once it is done, it is going to cause a lot of problems, and it's a cascade of diseases. The patient becomes bedbound, he will hospitalized, and then he will have multiple other things associated with the bedbound problems. So we are here to decrease the risk. So we wanted to minimize the risk, and we wanted to review these things earlier before the fall happens. There is a protectors. If you see any environmental factors, there has to be good lighting. It has any handrails, bathroom mats are very important for the environmental risks, to decrease the environmental risk in the patients who has fall. Complications: patient may have fractures, patient can have subdural hematomas, dehydration, electrolyte imbalance, pressure sources, fear of falling, and immobility. These are all complications of fall. So fall is actually impacting a patient's geriatric population very badly, and multiple systems are involved in that once the fall happens. Then we go on to the dementia. There is another problem in the female in the geriatric population is dementia, a loss of short-term memory. The patient may have aphasias, apraxias, and persistent and progressive. Dementia in elderly, you need to assess the medication list, as previously discussed, that even dementia can also you have any anticholinergics, opiates, NSAIDs. The patient can have these drugs attributing towards dementia. Warning signs: inconsistencies in the medical history, and word finding difficulties, confusion about medications. So these are all when you are assessing a patient with geriatrics. If the patient has these problems, that he's inconsistent, he is difficulties finding words, he's confused about the medication, so probably you can think that probably this patient has some dementias. Causes: Alzheimer's is the most popular cause for the dementia. There is another vascular dementia, Parkinson's disease, alcohol-related dementia, mixed causes of, and subdural hematomas. Some things which mimic dementia, but it is not actually dementia. Like if the patient is depressive, you've seen that he forgets things, but this forgetfulness is not because of the dementia, is because of the depression underlying. So you need to carefully evaluate a patient whether this patient has true dementia or it is something which is similar to that. Some drugs can also give you like that. Some because of the hypothyroidism, because of metabolic encephalopathies, vitamin B12 deficiencies, deliriums, they can also mimic as dementia. So discuss the patient about the diagnosis, fall prevention, correction of vision, physiotherapy, and prop treatment, nutritional support. This is all general support for the dementia and for the other geriatric population. So you also need to think of safety issues like if the patient has dementia, whether he or she is driving, using instruments, self-medication, some wanderings. So pharmacological measures, donazepam and rivastigmine can be given to patients who has dementia. Neuroleptics, avoiding situations, avoid confrontation, dealing with the patient. So this is all patients with the elderly have controlling agitations. So this is how you can do that, because a dementia patient can be more confused, can be more agitated. So you need to carefully review that and manage those issues. If there is hallucination, you need to deal with hallucinations, wandering, insomnias, and all that. There is another issue of nutrition. Um, I think we can skip that. Hypertension, diabetes. Well, when we discuss diabetes and hypertension, we can discuss in that. So it's not very important. And that's it. There is another. mm, okay, we discussed the functional assessment, the tools of assessment. For functionality, we discuss ADLs and IADLs. What are the, what is this ADLs and IADLs? Can anyone just recall ADLs and IADLs? What are those?
Outdoor activity and indoor activity or daily activity.
Okay. So assessing ADLs is indoor activity and IADLs are outdoor activities.
Yes.
This is how you are going to do it. You will measure, you will, what you are trying to assess, you are trying to assess the functionality of that person. Neurological assessment you will do by Minicock and MMSC. We will concentrate here in family medicine, Minicock. How are you going to do it? I will let you know. Nutritional assessment by saying by observing dentation, appetite, weight changes. Gait, you do get up and go test and time that, and any history of fall, you will assess the gait. Psychologically, you will assess the depression. Social support, you will also need to. So these are all tools which we need in a geriatric population. Tools means the examination points that you will do, specific tests that you will perform in patients, or specific points in the history taking. We discussed ADLs and IADLs. It is the repetition. If you take about I want you to concentrate on Minicog. This is for the cognitive function. Step 1, you will ask the patient to remember 3 words. You will give unrelated 3 words, maybe pen, fan, light. So they are all unrelated. So you ask the patient to remember these 3 words or any 3 words. Okay, number 1. Number 2 step is you ask the patient to draw a clock. So this is actually a distractor. So you will ask manually the patient that he has to draw a circle and then he has to draw a clock. Once he's done that, then you ask the patient to repeat repeat these previous words. So now then you will interpret. You will give 1 point for each. So you if the patient score is 0, that means it is positive that he is not able to remember all these 3 words. You ask the patient to give you give first 3 words. You ask the patient to draw the clock, and then you will ask the patient to repeat these 3 words. Now what will happen if the patient is not able to draw the clock or is not able to recall it? So his points is 0. So this is 0 and is positive for dementia. If the patient score is 1 or 2, that means he is able to recall 1 word, we will give 1 point. If he is able to recall 2 words, we will give 2 points. If he is able to recall 3 words, we'll give them 3 points. Um, if the patient has one or two with abnormal clock draw test, so the patient is able to remember, recall one or two words, but when you ask the patient to draw the clock, it was abnormal. He was not able to do that. This is also positive. The same score with one or two with normal clock draw test, it is negative for dementia. Okay. So clock drawing is if the score is one or two, then you need to see the clock draw. If the clock drawing is abnormal, then it is positive. If the clock drawing with the same score is normal, then it is negative for dementia. If the score is 3, that is able to do the normal clock draw test and is able to recall all three words, obviously it is clear that this score is 3 and it is negative for dementia. So this is how you ask the patient to draw a clock. You can ask the patient to draw a circle, and then you can ask the patient to, if you can draw the 9 o'clock or 12 o'clock or 3 o'clock. So you can ask the patient, or 6 o'clock or 7 o'clock. So you can ask the patient like that to draw the clock manually. Okay, this test is clear.
Doctor, I have a question.
Yes, please.
I will give the patient all the instruction and do a circle, then line, and then, or just tell him draw a clock.
You will ask, you will ask the patient to draw a circle and draw the clock. But in this, you can you can support the patient, because there is some kind of comprehension issues. If you think that there is a comprehension issue, then you can also draw the circle and then ask the patient, and you can maybe give some numbers, like here you can write 12, here you can write 3, 6, 9, and then you probably ask the patient to draw the line for 9 o'clock or 10 o'clock or 6 o'clock, like that. This is, even that is acceptable. Okay.
Yes, clear.
All right. Okay, now if I ask if the patient has if he's able to recall two words, but he's not able to draw the clock, what do you think? Is it is it positive for dementia or negative for dementia?
Positive for dementia.
Yeah. If the patient has one or two, he's able to recall two words, but he is able to draw a normal clock, then
Not dementia.
no dementia. Okay. Even though the score is 2, but here that it is of no dementia because of the abnormal and normal clock dot test. Good. We discussed the hearing losses, nutritional thing. I will skip that. Now I would like you to concentrate on get up and go test. You ask the patient to walk 10 feet, come back and sit down. Yeah, he has to walk. If he's sitting on the chair, you ask the patient to take 10 steps and then turn it around and then come back 10 steps and then sit down. And then you time that. How much time does the patient need? Number one. Number two, you also can observe for the gait. Number three, you can also observe that he or she is using something to do that. So up to 10 seconds, it is normal. 20 seconds, even 20 seconds are also acceptable, but more than 20 seconds, because from 10 to 20, it is normal. Above 20, it requires needs rehabilitation or evaluation, or probably you need to evaluate the patient that probably he's having problems with his gait. So you can suggest, or you can intervene and evaluate what is the cause for it to prevent from fall. Now we want to assess for depression. You will ask 2 screening questions. In the past 2 weeks, have you felt little interest or pleasure in doing things? Number 1. Number 2 is, do you feel down or depressed or hopeless? These are the 2 things you will ask in the history. And if the answer is yes, then you will say that okay, this patient is probably having depression, but this is just for the screening thing. You can take the opinion from the psychiatrist, or you can do some detailed testing of the depression. But these are very sensitive, and they are very decisive that the patient is having depression or not. Low interest or pleasure, which is called anhedonia, and depressed, down, depressed or hopeless. This is also the screening tool for depression. Social arrangements and all that. So that's about the assessment of a geriatric population. How are you going to assess it, and what are the different assessment tools that we have in our geriatric population?